All right, this is going to be a bit of a hope this works moment because I tried to just share the PowerPoint and I think I might be sharing the entire screen. So if anything pops up to destroy or to disrupt the visual, please just let me know. Welcome everyone. I am so happy to have you here. This is the FCS Supportive Housing and Supported Employment Service Providers Services Budgeting Session. We'll go ahead and get started. So I am Eva. I am based in New York City, but I am a senior program manager on our national consulting team. And so I work with teams across the country on various projects that operate at the intersection of healthcare, housing, and homelessness, looking at ways that healthcare and housing can partner together with the homeless sector to advance solutions that can help reduce homelessness in your communities. And so I tend to focus on ways that Medicaid and other healthcare resources can be utilized. And that is why we are here today. We're all here because we're interested in taking advantage of the Foundational Community Supports Program. You may already be billing the foundational community supports for the services that you provide. You may not and just be interested in learning how. So at whatever stage in the process you're at, we're happy you're here. And I will pass it to my colleague Stephanie to introduce herself.
Hi all, I'm Stephanie Cabrera, Aishi in her pronouns. I'm in Vancouver, Washington, so I'm here with all of you. I'm also a senior program manager with CSH, and I'm going to be talking very little in this presentation. This is going to be all Eva. So I'm here mostly as support. So if you're having any technical difficulties, anything on the back end that's not working for you, let me know. You can chat with me privately and I will work to resolve it. I also sent out the budget tool and the budget guidebook yesterday. If you didn't receive those, let me know and I can send them out again, just so that you have them as Eva is walking through. You can also follow along. But thank you all for being here. I also quickly want to call out, I know we have a couple of HCAs of the FCS program trainers here. I'm not sure who it is or who they are. So if y'all wanted to just in the chat while you're introducing yourselves, call that out in case folks have specific questions for you. We can refer them over to you as well. Cool. I'm gonna pass it back to Eva.
All right. So what are we going to cover today? Well, we're going to talk about the various staffing models for supportive housing and supported employment. We're going to talk about how to estimate your total cost of care and the potential Medicaid revenue that can be produced through the Foundational Community Supports Program. And then most importantly, as you all are probably, the reason why you're probably all here is to understand how to use the FCS services budget tool. And we also have a time study tool and a revenue projection tool. So to kick things off, Services Budgeting 101, this is probably not going to come as a big surprise to you guys. You want your costs to equal your revenue. Ideally, you wouldn't have your costs be more than your revenue, but various costs include things like personnel expenses, your operating expenses, startup costs if you're a new provider, and what we're really going to be talking about today is some ongoing Medicaid provider costs, because billing Medicaid does come with its own additional costs. And then various sources of revenue. So you're already familiar with grants. You may charge service fees. Maybe you charge private insurance. Perhaps you receive some in-kind support. And of course, while we're all here, we want to leverage some Medicaid reimbursement. And when we send these slides out, you will have access to these links that are here that take you directly to the budget tool and the user guide, which Stephanie also already sent to all of you. So we like to think about how there are sort of 4 lenses or 4 buckets for estimating costs. And I'm just going to say that I'm going to be kind of speeding through these slides because I think we're all here to really talk about the services budget tool. So I wanted to lay a foundation and some groundwork, but I will not be taking too much time on the slides. So if you have any questions, feel free to put them in the chat. Feel free to come off mute, and we can always, dig deeper, but I want to make sure we have enough time to actually get into the tool. So we talk about sort of four lenses of estimating costs. There's the programmatic bucket, the strategic bucket, the logistical bucket, and the analytical bucket. Programmatic includes all those costs that kind of go into running your program. Things like the costs associated with providing services, costs associated with personnel, so your staffing, supervision, the training that is required. Strategic is going to be things like what business partnerships are going to be there, thinking about sort of how to plan long-term braided funding opportunities. Now that you're bringing in Medicaid as a revenue source, you're going to be braiding that Medicaid funding in with your existing funding, which is most likely in the form of grants. And then some logistical things you need to take into consideration, things like your operations, your the costs of maybe having a staff lawyer, what are your HR costs, what are the IT costs, and then finally analytical data is a huge piece of all of this. You want to make sure that you are engaging in continuous quality improvement. So what data systems do you need, how much time do you need to devote to data management, do your data systems provide the right financial data that you need, the right operational data, things of that nature. So if you aren't sure where to begin in estimating your true cost of care, it's really good to just start with your existing caseload sizes, your current salaries, and your current operating expenses. So if you are a new program, this wouldn't really apply, but you will want to think about how you can build a program around your goals, and we'll be talking about that when we get to the service budget tool. If you're an existing program, you want to start with your existing expenses, and then you'll want to add these new added costs that come from being a Medicaid provider. And that will tell you your true cost of care. True or total, TCOC, we'll be referring to that quite a bit. So just to quickly go through the various roles in your service design, your provision, and your coordination, because if you are a new program, you're probably starting to think about your staffing model. So within the supported employment bucket, your staff are likely going to include a supported employment supervisor, maybe an employment specialist, perhaps a benefits counselor, and they will play the role of providing those pre-employment services, the employment sustaining services, and individualized benefit planning. And these are all sort of the key services delivered. Is someone asking a question?
I can't take you out right now. You have to lay down.
If everyone can mute themselves, that would be great. Thank you. So those are the services that are traditionally provided within the bucket of supported employment. With supportive housing, your main person is going to be that community support service provider. That is the term that Foundational Community Supports uses to refer to someone who's providing the pre-tenancy and tenancy sustaining services and working with the individual to service plan and to coordinate with other providers. The other providers are another bucket of folks who are going to be providing services. So as you're looking at your broader model, you don't necessarily have to be planning for your own staff to be delivering all of these critical services that your clients are going to need. What other organizations exist? What partnerships can be established? Or perhaps who do you need to hire to deliver these other critical services? These are individuals like doctors, nurse practitioners, nurses, substance use specialists, community health workers, and they're the ones who are going to provide your clients with medical care, mental health care, substance use disorder services, vocational and educational services. So these are the other direct services that individuals in supportive housing and supported employment traditionally need. And then there's the individuals who provide that broader care coordination. And these are like managed care organizations, ACOs, health homes, hospitals, and they're really responsible for that care planning and utilization review. And this is kind of the ecosystem model of the various supports that exist to help our clients thrive. And who are we supporting? We're supporting that supportive housing or supported employment client. They have the responsibility and the choice to voice their preference for services, their housing, their service planning, get to be active participants and drivers in their employment search. They have choice in the housing that they choose and the type and place of employment. And they are the leaseholder and they are the ones who are employed. So I'm not going to go into this too detailed, but I just wanted to include CSH's quality supportive housing standards. So these are CSH's sort of gold standard best practice for how to deliver high quality services within supportive housing. And I've included links to direct you to resources that we have shared on our website to walk you through how to design and ensure ongoing maintenance of a high quality supportive housing program. And what we're really focusing on are those supportive services. And that's because foundational community supports covers services. Now, the other buckets, project planning and administration, property and housing management, and community planning and engagement are all equally important in the comprehensive deployment of supportive housing. But within this context, we're really focusing on quality supportive services. And then this similar idea, this is a screenshot of the best practices in supported employment, basic characteristics from the SAMHSA evidence-based practice toolkit. And so, again, not going to go into this in too much detail, but we have added some little orange boxes around some of the key service staffing model components, one being that employment specialists traditionally manage caseloads of up to 25 consumers. Vocational services are provided in community settings, and assertive engagement and outreach are conducted as needed. And again, we link to the best practice toolkit for you to take advantage of and look at your own on your own time. So diving into some of the buckets that really help to inform your budgeting model, first and foremost, you're going to need to estimate your caseload size. And this is going to include identifying who you're serving. So are you serving higher acuity, more complex individuals that are going to need more time devoted to their support and care? If so, you may need to have lower caseloads. Or are you serving generally higher functioning, more independent individuals, and maybe you can manage slightly higher caseloads? Are your individuals new to supportive housing or supported employment? If you're working with a lot of new folks in these two programs, they may need more time and more care to transition and to stabilize. And so that also may impact your caseload. Within the supportive housing context, is it project-based, as in single site, or is it scattered site? If it's project-based single site, you could probably afford to have slightly higher caseloads because all of the services are being provided in one place. But if you're traveling to other places, if you're a scattered site program, you probably need smaller caseloads to take into account the fact that you are traveling, your staff are traveling to get to their clients. What is the best practice service model that addresses the needs of your client population? Different service models have different caseload sizes. Within the foundational community supports program, that is really focused on those housing support, tenancy stabilizing services like housing navigation or pre-tenancy supports, and those tenancy sustaining services like working with an individual to negotiate with their landlord, how to problem solve with a neighbor they're not getting along with, connecting them with resources, things like that. So those are slightly lower intensity services, but maybe those exist within a bigger ecosystem of services you're providing that require more intensive care. And then finally, are your staff new to supportive housing or supported employment? Do they require more training? Is there kind of an uphill approach, steep approach to getting them up to speed? That might also mean that they need to have slightly lower caseloads as they're onboarding. So again, I'm not going to go into this in too much detail, but we provide here a table of best practice caseloads for individuals that meet different population types. So for just standard individuals within a scattered site context, we kind of advise within the tenancy support service model that you have no more than 15 individuals you're serving per case manager or per community support specialist. Within single site, that can go up to 20. Whereas if you're working with individuals with developmental disabilities, for example, maybe you want to stick with 10. And within supported employment, there's a fidelity model that comes with sort of the best practices around how much time you should spend with your individuals providing those direct services and what those caseloads should be. So the lowest fidelity score is if one employment specialist has more than 41 clients and spends, less than 60% of their time providing direct services. Meanwhile, a fidelity score of 5 means that an employment specialist has 20 or fewer, and the service provision takes up 96% or more of their time. All right, and then some additional ongoing costs to consider in addition to just your caseloads. You're going to have staff training and supervision costs that you need to take into consideration, staff salaries, business support. So what are the various sort of operational costs and business costs that are required to maintain a program? What are the transportation costs that are required? What quality improvement is needed? What are the costs associated with quality improvement? And then IT and data. And then if you're becoming a new Medicaid provider, there are some additional costs to consider. And these are things like hiring a quality improvement manager, a compliance officer. Perhaps you're going to work with a Medicaid or billing support consultant. You're going to need to provide HIPAA and compliance training. There'll be operating expenses like liability insurance. And there are some additional hardware and software expenses you may need, like bringing on billing software or email and data encryption. Perhaps you want to get an electronic health record. There are also some general startup costs if you're a new provider, but I'm not going to go into those as much right now. But you can always take a look at this on your own time. Okay, so productivity. When we talk about productivity, we don't mean that your staff is being productive or not productive. We mean what percent of their time is spent performing services that are billable under the foundational community support model. Because FCS is only reimbursing for specific services provided. So what percent of your staff's time is spent delivering those specific services? And that's going to be calculated differently whether you're providing supported employment services or supportive housing services. Supported employment is calculated on a 15-minute increment model, which means that you need to take note of what your staff is doing every 15 minutes, and you get reimbursed for every 15 minutes spent delivering those services. Supportive housing is on a per diem model, which means that you get one rate paid per client per day. And so various factors that go into estimating how productive your staff can be from a Medicaid standpoint include things like time off. If your staff isn't in the office, they're certainly not providing reimbursable services. What time is spent conducting administrative tasks? Things like case notes and staff meetings, those are not billable services. Additional non-billable services include things like outreach and sometimes collateral contacts. So collateral means indirect. It depends on the type of service being provided, but sometimes if you are providing a service on behalf of a client as opposed to directly with the client, that wouldn't be considered reimbursable. Lunch breaks, travel time, those types of services are not reimbursable. Travel time comes with a caveat though. If it's travel with a client to a service that they're receiving. For example, if you're traveling with a client to meet a landlord within the supportive housing context, that is reimbursable because that is providing the service. It just happens to be that service involves travel. But if you're just traveling to a scattered site location, thinking of it sort of like as a commute, that is not reimbursable. New hire ramp up and onboarding, the types of trainings that are required, this is not going to be reimbursable. And then you'll also want to make sure that you buffer for time spent processing rejected claims, spent conducting authorizations, and engaging in quality assurance. So putting this all together to estimate your productivity standards, a great way to do so is to conduct a time study. And this is where you would basically walk through your staff's day in whatever like bucket increments make sense for you to understand how much of their time is spent providing that billable service. So just for example, in this table that we have here, activity on May 5th, from 9 a.m. to 9:45 is this staff member is working with Molly Moo to discuss where she wants to live. She spends 45 minutes doing that. Is this a billable service? Yes. So how many of units of service is she billing at? She's billing at 1 unit of service within that per diem bucket. Per diem means, and we're going to get to this more in the next slide, but per diem means that each client that you serve can be reimbursed once that day. And so she spent 45 minutes with Molly. That means that Molly is reimbursable at 1 unit. Staff meetings from 10 to 11, that is not a reimbursable period of time. And so the units of service provided that were billable is 0. Same with the 30 minutes of travel, 0. But when you meet with Jerry Jets to discuss the issue that he's having with a neighbor for 30 minutes, that is reimbursable at $112. So 1 unit. And then in italics at the bottom, I've switched from a supportive housing time study to a supported employment, just to give an example. So at the bottom, you see meeting with Jessica Rabbit to discuss employment goals from 1:15 to 2. That's 45 minutes, and it's a billable service, which means it's 3 units, because remember, this is a 15-minute increment approach. So 15 times 3 is 45. That's 3 units at $27 a unit. So these are the reimbursement rates within the foundational community supports model. So on the left is supported employment. Again, 1 unit equals 15 minutes of service. You can only bill up to 120 units, or the equivalent of 30 hours of service in a 6-month period. And you get to reimburse at $27 a unit. Services may be reauthorized if a participant continues to need services. So if after the 6 months, they need more, you can submit for reauthorization. And then an exception to the rule authorization process is available if additional service units within that 6-month period are required. So if you've exceeded 120 units, but this individual needs a lot more support, you can file an exception to rule to be authorized to provide additional services within that 6-month period. Within the supportive housing benefit, this is actually a per diem rate of $112 per day, and you can limit 30 days of service within a 6-month authorization period. And services may be reauthorized if the participant continues to need services, and you can also file that same exception to rule so that you can get additional days of service within that 6-month period for clients with high needs. And with that, I am going to now switch to the services budget tool. So let me pause my share. Let me exit my screen and let me resume sharing. Can you all see my screen? Let me see. I'm having Stephanie, can you give me a thumbs up if I'm sharing the tool?
You are. Yep.
Perfect. Awesome. All right. So this is the Foundational Community Supports budgeting tool. This is the landing page. It just gives you a brief overview of how the model works, of how the tool works, and it links you to the user guide, additional trainings that we provided within the FCS Medicaid Academy, and then contact if you have questions. We're going to skip the budget summary output and the annual total budget summary for now, because we want to go and complete the tool before we actually look at those summaries. So you're gonna jump from tab 1 to tab 4, which is basic input and assumptions. These are basic assumptions about your models that you're going to complete before you go into the models tabs. So first question, is this a new supportive housing and or supported employment program? If yes, it's going to populate with our suggested caseloads. If no, you will need to add your own caseloads, and I will show you that in a minute. Let's go ahead and stick with yes. Let's assume it's a new program. Do you want to include general startup costs in your budget summary? These are startup costs associated with just building a new services program. Let's go ahead and say no. Whoops. Let's go ahead and say no, because we do want to include new Medicaid provider costs because we're all here for the FCS program, and those have some similar costs. So we're going to say no to general startup. We're going to say yes to Medicaid. And then it asks you to determine which of the service staffing models you want to complete. Are you going to be providing community support services for supportive housing, or are you going to be providing individual placement services for supported employment? Let's say that you want to maybe try both. So we'll keep both at yes. And then these are your budget assumptions. And you are going to want to complete your budget assumptions. You can always keep the ones that we have included for you, but it includes things like your indirect costs, transportation to your scattered site locations, coordination travel, so traveling between service visits with clients if you're taking Molly Mood to meet a landlord, the federal mileage reimbursement rate, and this needs to be updated to 2024, which we will make sure to do. It also allows you to add in inflation because it provides you with a multiple year summary of your costs, inclusive of inflation. And then it allows you to also include time for, or a percent of your wages that should be devoted to staff training. And we sort of advise that training costs should be between 1% and 3% of your staff wages. So we just have here an average of 1.5%. And then finally, fringe. And then down here are the caseloads. And note, these are caseloads, not case sizes. The difference being this is the ratio between number of clients to staff member providing services. You will have the opportunity in the service models tab that we get to provide your overall case sizes, as in the total number of clients served, but this is just specifically the ratios. And in the peach boxes, we provide suggested caseload sizes. And if you have your own program that's already up and running, you would complete that here in existing program. You do not have to update these suggested caseload sizes. If you have your own program, you would add that in the existing program. If you want to update these suggested caseloads, you're welcome to. You do not have to. And then it's the same thing with IPS. We have on the left, we offer in both of these two models, populations that tend to be served by these various service models, excuse me, and then the caseloads generally associated with those populations. And then here we have the supervisor to supervisee ratio. We recognize that one supervisor should not supervise more than 8 individuals. I'm going to stop before moving on to just say that I know that this is probably seeming like a lot, and if you are not the most comfortable with budgeting tools or the most comfortable with Excel, it can seem like, oh my God, this is huge. I don't even know where to look. My best practice advice is look at the blue cells and the peach cells. Those are the cells that require your input. The blue cells are the ones that need your input, or you have the option of providing input to. The peach cells are suggestions that can be changed. The green cells are automatically going to be populated for you. You do not have to look at those. Those are the outputs. You only want to look at those when you're looking for results. So now that you've completed tab 4, we're going to go over to tab 5, the community support service model. And at the top, we provide you with an overview of the FCS program and its supportive housing model. And we also have a link here that you can click on to learn more. This is where you're going to start to set up your services staffing model. So you're going to start by identifying the populations that you serve. So let's say you serve individuals. Your recommended caseloads are automatically going to populate for you with the inputs from here. Remember, we said that this is a new model, so it's going to be pulling from the new model suggestions. So these are the caseloads that are automatically there, and then you would add here the number of tenants you plan to serve in scattered site or single site. So let's say you plan to serve 50 tenants in scattered site and 25 in single site. You now have total clients of 75. And then you can scroll down to your staffing model. So you've set up here your tenants, the clients that you're planning on serving. And then the staffing model populates for you with the suggested number of staff members. So based on the number of tenants, we recommend 5 community support service providers. And in the Peach cells, that populates for you. Now, you are welcome to override that. Maybe you want to have more, you want to have a smaller caseload, so you're actually planning on having 6 community support service providers. So you can override that. And then in the blue cells, you'll want to make sure that you add either their current salaries or the salaries you plan on paying them, or maybe you want to be aspirational and provide the salaries that you would like to pay if you actually had the revenue to be able to do that. And then we have the other specialists. Section 2A is broken into billing staff and non-billing staff. What that means is that we provide the specific staff member that is allowed to provide services that can be reimbursed by the Foundational Community Supports Program. Non-billing staff are those additional staff members that support your program, but do not provide services that are billable. Or maybe they provide services that are billable, but are not eligible within the eligibility criteria, within the provider qualifications to bill foundational community supports. Because when billing Medicaid, you have to provide Medicaid eligible services to Medicaid enrolled and eligible beneficiaries. And the person providing those services has to meet the provider qualifications set by Medicaid. So it's sort of these 3 factors that have to be set. The services have to be eligible, the recipient has to be eligible, and the provider has to meet qualifications. So within the foundational community support structure, only a community support service provider is eligible to bill Medicaid. So then we would, go ahead and provide the additional staff that you're planning on staffing your model with, and we provide some suggestions over here in the red. So based on the number of tenants, if you plan on having a peer specialist, we recommend 3 of them. We only recommend 1 program director, 1 administrative support. We don't have a recommendation for your housing manager. A housing manager is not someone who provides direct services. It's someone who maybe does outreach and relationship building with landlords, is not providing direct services to clients. So you may or may not have someone like that on staff. Maybe your community support service provider is serving that role. Maybe they are also developing relationships with landlords. If so, the time spent doing that would not be billable and would not factor into their productivity. So you'll complete that, and then you are going to move down to your Medicaid section. So you start by completing your units of service. You're going to add in how many hours a week your staff work, how many holidays you offer them, maybe additional paid time off or personal days, any other time off. And that's going to allow you to think, that's going to all contribute to the number of units of service that they are going to be able to bill for in a year. And then this is where you add your productivity. So thinking back to that time study that I shared with you, where you're going to walk through your staff member's day to figure out how much of their time is spent providing billable services, you would then basically take a percentage. So let's say 5 out of 8 hours is spent providing billable services. You would do equals 5 divided by 8. That's 63%. So now your productivity is equal to 63%. And that automatically calculates for you the number of clients that your community support service staff can probably see in a given day. And then it also will automatically calculate for you the annual units of service. So let's say that you have a 35-hour-a-week work week. That's fewer hours spent providing, working in the office. So with a productivity of 63%, you can only probably see about 4.4 on average clients per day. That's 994 per diem units of service that can be seen in a given year. And then underneath, it automatically provides for you your per diem rate at $112 per hour. So if you scroll all the way down to the bottom, it's going to pull all of this information to calculate for you your Medicaid reimbursement potential. $668,000 can be revenue generated from Medicaid annually. And then you're going to want to complete the budget tool itself. So wages and salaries and benefits are provided automatically for you. If you have any additional personnel expenses, you'll add those there. And then you're going to add all of your operating expenses. Remember, you don't have to update the green cells. You only have to update the blue cells. And you may not have those costs, right? You may not have nurses on staff. If you're just budgeting for your foundational community support service program, there are no nurses associated with FCS. So you may just leave this zero. But we use this tool in other contexts, and we want it to be helpful for you to think about the services you're providing and budgeting for within the broader ecosystem and how much the FCS revenue can offset those costs. And then you'll add your additional grants and all of that, and it'll show you your total revenue. Now, this is just your annual program expenses from this page. It does not include your annual Medicaid expenses. So remember, I mentioned that there are ongoing costs associated with being a Medicaid provider. Those costs are going to be completed in tab 9. Oh, tab 8, I need to update that typo. So we're going to go over to tab 8. These are your Medicaid expenses. First and foremost, you're going to select which tabs, which service models you want this to apply to. Do you want it to apply to just the supportive housing services, just to the supported employment services, or to all of them? Because we said that we want to complete both service models, we're going to apply it to all of them. And then to complete this tool, column B gives you a list of items that are traditionally included as costs if you're becoming a Medicaid billing provider. Column C will tell you whether these are required costs, whether they're required by CMS or required by the state. First and foremost, if it says it's required, you want to select yes to including this in your budget. And that's because you will have to factor that in. So then column F, you're going to add in your cost. Column G, you'll add in the total units. You'll make sure to select whether it's yes or no, and then it'll calculate your annual total. Column D will tell you how frequently this expense is going to occur, whether it occurs annually or whether it's just one startup cost. Now, if you wanted to hire, for example, a billing support subcontractor, this is someone who can actually conduct your billing services for you to alleviate some of the burden, the administrative burden, and the cost burden of having to do that yourself. This is going to be billed monthly. And generally speaking, billing agencies are going to take around 5 to 8% of your reimbursement of that claims monthly. So column F is going to pull in your monthly claim amount. So remember, this is going to be pulled in from whatever is listed here as your Medicaid reimbursement revenue. It's going to pull that in. We know that you're going to add in what, either an estimated, or if you have a billing subcontractor already in mind, you're going to pull in, you're going to add that percentage here. And then under annual total, right now it's not adding it in because it says no. If we say yes, it's going to calculate how much annually you can expect to have to spend on this billing support subcontractor. And then when you scroll down all the way to the bottom after completing this whole tool, row 52 will show you your total startup costs, and row 53 will show you your total ongoing costs. If we go back to tab 5, you will now see ongoing costs added in column E. You now have 112,000 annual program costs associated with Medicaid. Column F is going to show you your annual budget that includes just these program expenses and your Medicaid expenses, but it will not include your startup costs yet. So this is equivalent to just your basic annual budget without those additional startup expenses. So you can see now that your annual budget is around $888,000. Your Medicaid reimbursement is at $668,000. So you have a negative revenue of $220,000. So that means that you now know you have to make up $220,000 in other sources of funding. And this is where that braiding comes in, where you can say, okay, Medicaid can cover, $600, like almost $700,000 of my services. I'm going to have to find, additional grant funding to cover the remainder. And then column G are those additional startup expenses. So it's pulling in this 240 from tab 8. If you scroll down, along with the indirect costs, your total comes to 276. So then if you scroll to column I, this is your columns I through L is your multi-year budget. Year 1 is going to be your annual budget, or column F, with your startup expenses, or column G. So your total annual budget for year 1 is $939,000. Your revenue again is $668,000. And so you're now operating at a loss of $220,000. Column J is going to be year 2, which is just going to be your annual budget. It's not going to be year 1 because you're not going to include any additional startup costs. It's just going to be that annual budget. And then year 3 is that year 2 budget with inflation. And if you ever forget how these columns are calculated, the red tabs will show you. So year 2 equals year 1 minus your startup expenses, so the equivalent of your annual budget without startup times your annual inflation rate. Year 3 equals year 2 times your annual inflation rate, and then your grand total is a sum of years 1 through 3. The peach cells, again, automatically calculate for you. However, we did not lock them. We made them peach and not green, because if you know that your costs are going to change, if there's going to be any variation, you can go in and manually update that yourself. Maybe you know that in year 2, you plan to hire additional staff, and so you need to change the costs associated with year 2. The annual inflation rate, again, is pulled automatically from your basic assumptions. So that is your multi-year and annual budget for the community support services supportive housing staffing model. If you go over to IPS, it's very, very similar, except it provides the budgeting for supportive employment. But you would complete it the exact same way. It pulls the same assumptions. And again, you would add either your general startup costs, which we selected no, so it doesn't populate. But if we had selected yes, you can complete these general startup costs. And then again, you would make sure that your Medicaid costs are there as well. And then finally, what I want to mention is when you look between your general startup costs and your Medicaid costs, some of the items are the same. For example, rows 29 and 30 include desks and chairs. If you go here, we have desks and chairs in rows 33 and 34. If you have values in either of these rows that match, so let's say you completed desks and chairs in tab 7. Even if you add those values to tab 8, your annual cost is going to remain 0. And that's because we want to prevent you from duplicating those costs. So it's a safeguard that the tool has to prevent you from doubling up or replicating a cost that you've already accounted for. So with that, I am going to stop. I know I went through this very quickly, and it's a lot of information. I'm going to stop. I'm going to ask that folks, because I can't really see the chat easily, I'm going to ask the folks or hands raised, come off mute and just go ahead and ask questions. You also don't have to ask any questions right now. If this was like really overwhelming and you need to process it, totally fine. You can set up office hours with us to walk through it in more detail and apply it more directly to your own programs. But for now,
and we do have office hours in a couple of weeks. There's a couple of questions in the chat. One says, how do we count for part-time employees? I think you kind of touched on that.
Yeah, great question. So if you have part-time employees, then you can just limit your FTE. So let's say you have a half employee of 5.5, you can do 5.5. I need to update this to have more, to increase the decimal points. You'll see that the value is still equivalent to 5.5 here in the formula bar. It's just rounding up in the display. To avoid confusion, I will make that update and be sure that you get the pool that has higher decibels.
Oh no, this is a question for us. If the trainers are here, it might be more for them. What is the requirement to have a state licensure for having a Medicaid program?
Good morning. Hi, everyone. My name is Jackie Blasco. I'm one of the trainers with the Healthcare Authority. So Shannon, that's a great question. For FCS specifically, which is what I can speak to, there is no state licensure. It would be a contract directly with our third-party administrator, WellPoint, formerly known as a Mirror Group. I'm going to drop my email in the chat. If you want to connect and learn a little bit more, I can tell you more about sort of what it would be like to bill Medicaid for FCS specifically.
Thank you.
So I see another question. Is the 6th month for supported housing going to be extended to 1 year of authorization? That also, I believe, would be a question for one of the trainers. I haven't heard of that changing, but there may have been decisions made that I was not privy to. So if any of the supportive housing trainers are on and can answer Catherine's question.
Yeah. Hi again, Jackie. Catherine, it's not an expectation per se. A lot of programs will braid funding because depending on kind of which world you come from, whether it's nonprofit or a social service for-profit or like a behavioral health organization that already bills Medicaid, a lot of the time, like a fee for service pay reimbursement can be amazing in terms of being kind of a flexible type of money coming in, but also it takes a little while to build and scale if that's your only way that you're billing. And so there are programs that run FCS exclusively and don't braid any funding. It's not a requirement or expectation either way. There are a lot of people that kind of are able to make things pencil a little easier when they are braiding with other funding that they have, whether it's grants or other contracts they hold.
I
Sorry,
appreciate
Jacqueline,
that. Oh,
Actually, the question that I was directing to you was about whether there's a plan to extend the authorization period from 6 months to a year.
Oh no, I think I lost you guys for a second.
I was, so Catherine's question about braiding funding was not the one I was directing to you. I was actually directing the question about whether there is a plan to extend the authorization period from 6 months to a year. Are you with us, Jackie? I think we might have lost Jacqueline. So we'll hold off on that question, Catherine. It's a great question. Like I said, I hadn't heard anything about that changing. It's an important question, and we want to limit the administrative burden, of course, because the exception to the rule obviously is, you know, quite burdensome to have to continue to do that. But it looks like we've lost Jacqueline. So once she comes back, we will ask for that again. But Jacqueline went ahead and answered the braided funding question for me, which was great. Great answer. You do not have to braid. It would be helpful. I think most service providers find that purely Medicaid revenue is not necessarily sufficient, at least not in the beginning. What I'm going to point you to at the bottom of the Medicaid tool is like a ramp up that we show you, and it basically helps you figure out what percentage of your budget can be covered by Medicaid reimbursement over a period of time. Because again, there are various factors that can influence your revenue coming in. Maybe you submit a claim that doesn't get approved for whatever reason. Maybe there's a delay in payment going out. The administrative burden can be intense, and maybe you need to on-ramp up to actually reimbursing. So having those additional sources of revenue to help sustain you is advisable, but it's entirely up to you. There's no requirement either way. And Jacqueline, welcome back. So the initial question that Catherine had was, is there a plan to extend the 6-month authorization period up to a year, given the administrative burden of having it only be a 6-month window?
That's a great question that I can actually answer. Sorry about that, you guys. I also got trapped in the matrix there for a minute, so thank you for being extra patient with me. Catherine, actually, yes. So with our most recent 1115 Medicaid transformation waiver renewal that was re-upped officially July 1st for just supportive housing, if you're also a supported employment provider, it will remain at 6 months for service authorizations. But for supportive housing specifically, that will be transitioning to a 12-month authorization period. So there is a little bit of infrastructure that comes around sort of rolling out those changes. So it's not live just yet, but it's coming soon. And a lot of people had that feedback that it was a lot to do every 6 months. And so hopefully that's good news across the board, and it won't be too much longer before it's rolling.
Awesome. Thanks so much, Jacqueline. It sounds like that was great news for Catherine.
Yay!
And I'm going to address Amika's question because it's a good one. So driving time really depends on the type of driving that is happening. So if you are just commuting, so if you are a community support service staff member and you are driving to your client's unit to have a meeting with them, that is not part of your direct service time. That would not be factored into productivity standards. However, if you are with your client, say taking them to the Social Security office to apply for benefits, that would be a billable service. So it really depends on the service. And what I advise is if you go to the WellPoint employee or provider manual, excuse me, the WellPoint provider manual for FCS, it lists out very clearly the very specific services that are billable. I believe I also linked to them here. Oops, looks like the link is broken. I will have to fix that and send it out to you again. Yep, for some reason not working. So I will make sure to fix that. But we do offer, we do connect you with the specific services that are billable. Any other questions in the last minute before, so that I don't keep you over? We have one more minute. All right. Well, with that, thank you all so much for coming. I'm going to stop sharing my screen so I can see all your names. It has been a pleasure walking you through this tool. I apologize for some of the glitches that occurred. I will make sure that they are fixed and we will send you a version that is not glitchy. As Stephanie and I both mentioned, we are going to be providing office hours, and we also are happy to provide one-on-one TA. And so please feel free to sign up for that. And reach out if you have any questions. We will follow up with you with the recording and access to all of these tools. And with that, I hope you have a wonderful start to your day.
I also popped in the eval link in the chat. If y'all wouldn't mind taking the eval, I threw in our emails, and the next open office hours is, or the open office hours session is April 10th at 8:30 to 10, I think. But yeah, if anything comes up, you have our emails, feel free to reach out and ask any questions. Super happy to connect and support you on this journey. Thank you, Eva. This was great.
My pleasure. And we'll stay in a little longer. If anyone has additional questions, we'll be here for a few more minutes.